Hi, my name is Joseph Malo, representing West Hertfordshire Hospital's NHS Trust. We audited outcomes in metastatic axillary nodes following neoadjuvant chemotherapy for breast cancer, a 9-year review from a single cancer center. Neoadjuvant chemotherapy is increasingly used in breast cancer treatment. Chemotherapy can downsize the tumor, facilitate breast conservation with improved cosmetic outcome. It also provides opportunity to assess tumor response in vivo. Our aim was to determine the outcomes of axillary metastases following neoadjuvant chemotherapy in primary breast cancer patients. A retrospective analysis of patients treated with neoadjuvant chemotherapy between January 2011 and December 2019 was undertaken. Patients with stage 1 and 2 breast cancer found to have axillary macrometastases on pre-chemo sentinel node biopsy, ultrasound-guided fine needle aspiration, or core biopsy, irrespective of primary tumor characteristics, were included. Excluded were patients with recurrent cancer, patients on primary endocrine therapy, and patients with cardiomyopathy. All patients underwent full axillary node clearance following neoadjuvant chemotherapy, as this was the unit policy. A total of 155 patients underwent neoadjuvant chemotherapy between this period. 118 patients satisfied the criteria for inclusion in this study. All were female, youngest was 31 years old, and the eldest was 75 years of age. 39% of patients had no further metastatic lymph nodes, with 40% showing treatment effect within the nodes. 41% had partial response and 20% had no response at all. 34.7% had PCR response for both tumor and axilla. Our results are comparable with published data as demonstrated in the meta-analysis chart. Post-chemotherapy response in relation to tumor characteristics were analyzed in terms of phenotypes, grade, and receptor immunohistochemistry. Time does not allow me to go into details, but the breakdown is illustrated in the charts and tables in our poster. In conclusion, our results show 39% of patients had no residual axillary disease following neoadjuvant chemotherapy. Published data show a positive correlation to disease-free survival in this group of patients. It follows that axillary clearance can be safely omitted for this group of patients. Whilst de-escalation of axillary treatment is advocated, completion axillary clearance is still indicated in patients with residual disease and provides useful prognostic information. 61% of our study population showed residual disease in the lymph nodes. Clinical, pathological, and molecular profiling, coupled with more in-depth predictive markers, are needed to select patients who respond well to neoadjuvant chemotherapy and can safely avoid axillary clearance. Thank you for listening to me.